In the words of John Rawls, there could be no justice without fair opportunities for all. Justice demands the protection of those fair opportunities. Imagine this scenario: a tertiary city hospital in a capital city of an African country with 1,500 beds, a hospital with over 3,000 patients and an annual admission of 180,000. In the backdrop of severe scarcity, 1/3 of these patients die during their hospitalization, and another third die within 2 months of returning home. These deaths amount to 100,000 people annually, the equivalent of a New England town that is erased from the surface of the earth every single year.
Ladies and gentlemen, I have the privilege of welcoming you to this session. Thank you for joining. Wherever you are, good morning, or good afternoon, or good evening. I'm Nelson Sewankambo, a professor emeritus at Makerere University in Uganda, and I am your moderator for this session. First and foremost, permit me to extend our heartfelt appreciation to the unsung giants that have worked extremely hard behind the scenes to make this session a reality. You will not see them or hear from them in this session. Let me introduce them briefly. They are Declan Kiren. He is the chairman and managing director, Science Summit at the UN General Assembly 78. Second is Peter Gomez, who is the co-chair Science Summit, and Amanda Wallace, who is creative editor of e-magazine and blog. At the New Vance Health, University of Vermont, Lana College of Medicine, together with Swapnil Pav, who is a convener and is also from New Vance Health. And last but not least, Majid Sadiq, who is the convener and founder and immediate past executive director of Majid Sadiq Global Health Academy at New Vance Global Health. With those few opening remarks, let me refer you back to what you heard Mitra Sadiq say at the beginning of this session. What she said captures a very troubling and unsettling issue in the world about inequities in global health. Many factors contribute to these inequities, but we shall focus on the theme of shifting power paradigms towards an equitable global health stewardship. This session we are in aims to provoke a comprehensive discussion on the existing power dynamics within the global health governance and intersectoral partnerships. We aspire to inspire a shift in these dynamics towards a more democratic and balanced global health stewardship. We hope to produce a comprehensive roadmap for a more inclusive, equitable, and democratic global health system. Our goal is to create a shared understanding of the unique challenges low and middle-income countries face and come up with possible solutions, thus stimulating collective efforts to achieve health-related sustainable development goals. By engaging various stakeholders in these discussions, we hope to highlight the value of a bottom-up decision-making, community engagement, and democratic global health governance towards the equitable achievement of the health-related SDGs. This has potential to integrate digital medicine, including artificial intelligence, artificial AI, into the existing healthcare systems of low and middle income countries. Although global health activities are on the increase throughout the world, low and middle-income countries have benefited less than the richer nations. Equity has remained elusive for many LMICs, especially in Africa. It is indeed morally unacceptable for LMIC populations not to be able to contribute or enjoy their full lives potential as they suffer illness and premature death from treatable or preventable conditions because of poor access to treatments or methods widely available in richer countries. Social justice demands that urgent action be taken to address these imbalances, and preferably before the next major epidemic or pandemic. We should escalate our efforts, building on the concerns and momentum gained from the COVID-19 pandemic inequities. Health inequities not only impede development, but also cause humanitarian crisis and health insecurity to the global community. Additionally, LMICs are lagging behind on many health-related SDG targets. How can the global community achieve the SDG-related ambition of leave no one behind, which for now seems unlikely to be realized? I hope this session might encourage all of us to become global health leaders and change agents and mobilize others, because if we are united as one global community, the power is in our hands to change the world. There is a need to rethink and commit to undertake drastic changes, otherwise the inequities may get worse. The Africa we want is one with accelerated performance on the UN SDGs 2030 agenda and the African Union Agenda 2063, both which aimed to transform the continent into a global powerhouse where poverty is eradicated in one generation and science and technological innovations drive socioeconomic transformation. At this moment, let me turn to our distinguished 5 expert panelists from 5 countries: Botswana, Uganda, Zimbabwe, Australia, and the United States. Each one will do a brief self-introduction as he or she starts to deliver his or her talk. The panelists will focus our attention to stimulate discussions by addressing the good, the bad, and the ugly in global health, like the exploitation of low and middle-income countries. They'll also talk about the path led us here, where we are, that is, to global health inequities, and still maintain them and the need for working together to build a more responsible world and realize significant shifts towards equitable, democratic, global health stewardship and partnerships. Can low and middle-income countries actually contribute more to global policies and decisions? Finally, the potential impacts of rapid evolutions of global health technological innovations on the low-resource environments. After the panel discussions, we shall take questions, comments, and suggestions from you, the participants. Please share freely your thought-provoking contributions that may uplift Africa from rhetoric to action. Promptly post your questions and comments as they arise in the chat box. When you want to speak, click on the raise your hand button or the key. Now it's time to call upon our first panelist, Mitra Sadiq, who is a senior medical student at Stony Brook. She's a writer and editor and a researcher at the University of Vermont College of Medicine. Mitra, the floor is yours.
Thank you for the introduction. Hello, everybody. Welcome to this session. I am Mitra Siddiq, and my main focus area in global health the last few years has been on working collaboratively to overturn the colonial mindset and practice in global health. We center the breadth of our focus in global health on the question of how to close the equity gap, while only peripherally considering the question of why the gap exists. Without understanding the origin story, we are constricted to placing a temporary bandage on a much deeper incongruence. To understand the global health landscape, it's essential to first be aware of the systems and structures that created it. At its origin, colonial medicine was rooted in colonialism, which divided and disempowered indigenous communities through racial, ethnic, environmental, and financial inequities. Its legacy in subsequent exploitation of countries and communities drained their resources, impairing their ability to develop strong health systems, which under colonial rule were centered on mainly protecting the health of Europeans. Colonizers began and perpetuated extractive industries, including slaves, ivory, sugar, cotton, rubber, and tea, thereby exploiting colonized people, resources, and land, all while contributing to the spread of many infectious diseases that now ail low to middle income countries, such as malaria and yellow fever. As countries fought for liberation throughout the 20th century, emerging leaders inherited nations with inadequate resources to deliver on promises of human rights, such as universal health care, education, and jobs. The major international financial institutions, being the World Bank and the International Monetary Fund, both majority backed by the United States, gave these nations loans that were conditioned on structural adjustment, favored by investment in private sectors. And this resulted in fewer civil servants like doctors and teachers, limiting funds for public infrastructure like hospitals, schools, and public goods. Ultimately, this prioritized market freedom over human rights and development. And by the mid-90s, these countries had massive debts, meager health budgets, and exceptionally weak health systems. The debt of these nations ranged from 64 to 686 billion from the 70s to 80s, and that figure is rising. It rose to $860 billion in 2020. So our narrative today often touts that colonization is of the past and it's somehow irrelevant. Yet neocolonialism, which is the maintenance of the same oppressive system, but under the guise of economic, cultural, and political dominance, is perpetuating these same inequalities. We speak of Africa being a poor continent, but we don't ask how it came to be that way. We neglect to address the billions of dollars leaving the continent every year in the form of debt repayments, profits made by multinational companies, illegal logging and fishing, and remittances. It's a combination of inequitable policies, huge disparities in power, and criminal activities perpetrated and sustained by wealthy elites both inside and outside the continent that are keeping its people in poverty. And this is the case for other regions around the world as well. Outright military conquest and invasion, which has been largely transformed into neo-colonial exploitation in the form of military bases, extractive industries, and unjust loan distribution. The figures are staggering. $1.4 trillion left Africa in illicit financial flows between 1980 and 2009. So contrasting this idea that Africa is receiving so many funds from abroad, quote, the illicit hemorrhage of resources from Africa is about 4 times Africa's current external debt, according to a joint report by the African Development Bank and Global Financial Integrity. So when we come to the Sustainable Development Goals, how can we reasonably speak of SDG 1, no poverty, without changing the structures that continue funneling money and power directly from low to middle income countries to high income countries? SDG 2, zero hunger, when neo-colonial powers are putting African farmers into generations of debt through unjust seed selling practices. SDG 3, good health and well-being, when less than 1% of COVID-19 vaccines are reaching low to middle income countries. SDG 4, quality education, when capacity building is largely a lip service pursuit. SDG 9, industry, innovation, and infrastructure, when high-income countries conduct and publish research without due credit to people, communities, and resources in low to middle income countries. SDG 11, sustainable cities and communities, when neo-colonial powers continue to strip former colonies of all their natural resources. And SDG 16, peace, justice, and strong institutions, when our systems are based fundamentally in these colonial inequalities. We speak of low to middle income countries relying on high income countries for the latest evidence-based medicine, yet fail to address the reality that most research conducted focuses on the costs and benefits to the privileged of the world, and the findings are not transferable to the global masses who live in low to middle income countries. The COVID-19 guidelines, which have been widely discussed since the onset of the pandemic, are a perfect example. Wealthy elites can work from home, order their food online, but what about the rest of the world that's living paycheck to paycheck and doesn't even have access to the internet? We continue this narrative of people from high-income countries doing the noble thing to go to other countries to help when they are mostly enhancing their own education and ultimately its expected benefits, often at the expense of local people and communities. We speak of people in low to middle income countries having weak systems without admitting that people in high income countries have had a huge hand in creating and perpetuating those systems, taking away countries' autonomy and criticizing when they fail to fully recover amidst continued foreign intervention. The origin story for how global inequities came to be and the ways in which they are being perpetuated has been lost. This results in many well-intentioned people working hard in the wrong ways, resulting in a continued cycle. When the origin story is lost, our action items are based in a false narrative and are therefore largely ineffective. We continue these narratives. We pass them forward to global health advocates in high-income countries who continue to chase solutions and neither know the origin story nor hand the reins to those who know the story all too well because they've lived it again and again. Without understanding the origin story, we are constricted to placing a temporary bandage on a much deeper congruence. To move forward in a meaningful way, we need to hand the podium to people in low to middle income countries, remembering that the people who bear the unseen brunt of social change are the ones most impacted by the issues that call for that change. We need to reclaim the true narrative and create goals that are tangible and achievable within the context of accurate information and ethical storytelling. I don't anticipate that we will have all the answers today, but I'm grateful for the opportunity to give the podium to our colleagues to share their thoughts, challenges, and creative strengths. Thank you.
Thank you very much, Mitra, for those very insightful comments. And we'll get back to those in the discussion as panelists, but also with the audience. So let's go to our next panelist, Vincent Sektari, who is an associate professor of family medicine from the University of Botswana in Botswana. Vincent, please, you can say a few more words of self-introduction before you give your talk.
Thank you, Prof. Nkambo. I'm indeed Associate Professor of Family Medicine at the University of Botswana in Southern Africa. Allow me to talk about global health. There are different definitions of global health as people hold different views of what it is. This lack of a single definition of global health is therefore an opportunity for low and middle income countries to contribute to the definition of global health. Global health can be seen as a space where we engage with global social factors that are beyond the control of one nation, which global social factors influence the health of communities around the world. I'm therefore reminded of one global health author who wrote that where a person lives should not determine his lifespan nor the state of his health. In the past, global social factors were mostly beyond the gaze of health professionals because health professionals concentrated mostly on patients and the medical interventions that they used to alleviate their patients' problems. Thanks to social determinants of health, Millennium Development Goals, Sustainable Development Goals, health professionals are increasingly aware of the factors that impact the health of their communities. Factors such as economics, politics, social media, power, climate, and war. These global social factors need to be addressed at a global level in multilateral organizations to improve health in low and middle income countries. These global social factors and their impact on the health of communities around the world should therefore be the main subject of global health. Global or multinational organizations cannot, as presently structured, deal with global health problems such as global health effectively. Global institutions should become truly democratic and equitable in their administrative structures, as well as global policy formulation. Only then can they begin to understand the challenges of the various regions of the world and deal with them comprehensively. Let's talk about power. There are many forms of power, and they include military, political, economic, institutional, national, charismatic, media platforms, and artificial intelligence. Power can be wielded directly or indirectly. These other forms of power are the instruments by which nations, groups of nations, institutions, and other agencies bring about results that they desire nationally and globally. The United States of America, Western European countries, Russia and China have this kind of power, the power to influence and change events around the world. The United States of America and Western European nations have for a long time used their power to determine or influence trade, economic, political, health, and financial policies at a global level. They have engaged in war after war for decades and employed economic power and sanctions to promote their interests around the world. These Western nations have prescribed Western values and Western democracy to other countries as if they are the only fountains of wisdom on the globe. These same prescriptions have largely been self-serving to the detriment of low and middle-income countries. There is hope, however, because the world is transitioning to a multipolar world in which no country or region will cower under the might of another. In a truly multipolar world, global institutions must be located around the regions of the world and not be resident in the United States of America or Western capitals only. Therefore, the United Nations Security Council, World Health Organization, International Monetary Fund, World Bank, and the World Trade Organization must be democratic in their representation and executive leadership so that they are not dominated by one bloc of countries. The global community should come to a place where no bloc of nations control trade, finance, financial transactions, and the value of goods and commodities. I will come back to global health and what its role should be. Where you live should not determine how long you will live and the status of your health. Global health should address global health inequities so that people around the world enjoy good health as a right. Individual health is not only an individual responsibility, but a national and a global one as well. Availability of better medicines and technology will not necessarily lead to global health equity. The health of a nation improves when it creates wealth for its people to eat better, live in spacious, well-ventilated houses, control the environment to produce food, more food, and to reduce pests in the environment. Medicines and medical technology supplement these, as proved by the near eradication of TB in many Western countries until recently. The wealth of poor nations will grow if they begin processing their raw materials and other resources, and also protecting their nascent industries from the multinational companies of high-income countries. The health of their communities will improve as their wealth increases. Equitable global health governance, democratic and equitable distribution of economic, political, financial, and military power, as well as trade, should be the concern of global health players. Global health should therefore be the marketplace of ideas of all people, of all professions, and of all persuasion. I thank you.
Thank you very much, Vincent, for those very provocative contributions. And again, we will go back to those in the discussions. Let's now go to Kilazo Delovu, who is an associate professor of internal medicine and is from the University of Zimbabwe. Over to you. And again, please feel free to say a few more words of self-introduction. Over to you.
Thank you, Professor Nkambo. Today, I'm Kilazo Delovu, an associate professor of medicine from the internal medicine unit at the Faculty of Medicine and Health Sciences at the University of Zimbabwe. I'll continue with this issue on global health. Global health stewardship assumes that good governance within global health will result in policy making that serves the public interest. Do our countries have corporate governance principles that the citizens can judge them against if national and/or international goals are not being achieved? Most of our countries approved the SDGs. However, the UN SDG 2023 report shows that only 15% of the SDGs are on track for achievement by 2030, and we are unlikely to achieve them all at the current pace. The COVID-19 pandemic caused a dent in the trajectory, significantly affecting global health activities and testing global health governance. During COVID-19, global health stewardship was found wanting as countries seemed to forget that they were interdependent and as a world, and that we needed to work collaboratively to find solutions to the COVID-19 pandemic. How do LMICs contribute to this global health stewardship? This mission looks bleak as the LMICs are not included or have limited inclusion in decision-making global health organizations such as WHO, United Nations, World Bank, the Global Fund, to name a few. According to a 2022 study, high-income countries represent 75% of global health governance, despite contributing to only 16% of the world's population. At the Global Fund board, for instance, there are 20 voting members with only 3 representing Africa. The Global Fund is a massive contributor to health-related activities. How much community engagement do we think these 3 voting members representing Africa could have conducted to allow Africa's voice to be heard? when setting priorities at that level of governance. Our LMICs have generally not funded health expenditure to the extent expected. For instance, we've not achieved the 15% of the annual national budget that they're supposed to allocate to health according to the 2001 Abuja Declaration. In Zimbabwe, in December 2022, Zimbabwe's Ministry of Health and Child Care's budget stood at 11% of the national budget. It was inadequate and heavily dependent on external financing. As we strive to achieve the SDGs, should our low and middle-income governments prioritize health issues such as SDG 3, which refers to good health and well-being, or should they prioritize economics, i.e. SDG 8, which is about promoting sustainable economic growth and jobs? After all, the social determinants of health, i.e. the non-medical factors contributing to health outcomes, account for 30 to 55% of the health outcomes. In Africa, our perceived poverty, which has already been referred to earlier on, drives global health practitioners to want to come and help us, and thus perpetuating the power imbalances that we are trying to address. Zimbabwe's vision is to be an upper middle income country by 2030. According to the World Bank's Zimbabwe Country Economic Memorandum of 2022, this will require 8 to 9% annual productivity growth rates, which are quite ambitious. Are we setting ourselves for failure given such ambitious targets? Africa is said to be the most resource-abundant continent, with 40% of the world's gold and 65% of the world's arable land, but remains the poorest continent in terms of GDP per capita. Why should we expect to receive funding given all these resources? Why are we failing to capitalize on our abundant natural resources? Is it a lack of knowledge on how to use these resources, or poor governance on our part? Or are we being prevented from capitalizing on our resources by global health governance? The attainment of goal 3 for health depends on achieving all the other goals, as I've said before. It's about addressing poverty, inequality, climate change, environmental change, peace, and justice. Thus, multi-sectoral work, capacity building, financial sustainability, and data availability will be crucial to accelerating the implementation of the SDGs. Given these crucial factors, what new strategies can the low and middle income countries introduce halfway through the lifespan of the SDGs? Although we have managed to tame HIV and AIDS in most of our countries, we are facing upcoming non-communicable disease epidemics, i.e. multimorbidity, which will include hypertension, diabetes, cancer, aging, and HIV, to name a few, unlikely to be cheap to manage, especially dealing with the complications of these diseases, which will happen in both high-income countries and low and middle-income countries. The resources to address multimorbidity must be shared by both high-income countries and low-middle-income countries. Will we see equity in using the global health resources to manage these diseases, which will affect both the high-income countries and low-middle-income countries? According to the UN Secretary General Antonio Guterres, the root cause of the failure of LMICs to attain the SDG targets needs, quote, deep reform of our outdated, dysfunctional, and unfair international financial architecture, as well as we have not managed to ensure that the benefits of globalization flow to all. Various economic structural adjustments in Zimbabwe from soon after independence in 1980 to the early 90s have kept our country dependent on external financing whilst incurring major debts. This applies to most low middle income countries. Global health activities in LMICs have resulted in our reliance on external funding. Does this funding contribute to the economic development of our countries? Does the funding reduce our country's dependence on global health initiatives? Will global health organizations really strive to make themselves irrelevant in the near future by encouraging or supporting our countries to be more self-reliant, i.e. working themselves out of their jobs? There is likely to be conflict of interest here, as the current structure of global health stewardship is unlikely to empower low middle income countries to become self-sufficient. In conclusion, to achieve the SDGs by 2030, low and middle income governments must aim to financially support their social determinants of health, and not just healthcare delivery, which they've obviously failed to do, given that most of our countries in Africa have not achieved the Abuja Declaration of 15% as the minimum. To achieve the SDGs by 2030, the LMICs cannot continue business as usual. We need a major paradigm shift. We need to have our countries striving to use their own resources to support health goals, i.e. SDG 3, rather than expecting the international global health initiatives to take care of most of our national health budget, as is currently the case. I thank you.
Thank you very much again for those thought-provoking contributions. I would encourage the audience to remind you to post your questions, your comments in the chat box, and we'll get back to those later. But also, we are interested in hearing your suggestions. How do we solve these problems that you keep hearing about? How do we open a new chapter so that African countries and other low and middle income countries can actually accelerate in moving forward? Let's move on to the next presentation by Sabrina Bakera Kitaka, who is a senior lecturer in pediatrics from Makerere University in Uganda. Sabrina, as others have done, please feel free to add some self-introductions as you see fit. Over to you.
Thank you very much, Chair, and thank you so much for having me at this amazing panel. My name is Sabrina Chitaka. I am a pediatrician. I'm also an adolescent medicine specialist. But at this panel, I will be talking about global health and global health research and the disparities that come with it. I wear a hat where I am the vice chairperson of a grants management committee for the Research and Innovation Fund at Makerere University. So we have heard from all the speakers about the different versions of global health definition. And we know that it's difficult to define global health as it is. I like the definition, which says that global health in its broadest term is defined as the area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Whether that is possible or not, we shall see as we continue. Now, we cannot separate global health from global health research, but we know that global health research is marred by a lot of inequities. Some of these inequities are linked to the current approaches to research funding. There are so many imbalances of power and resources between the high-income countries and the low and middle-income countries. We know that the majority of research funding comes from the high-income countries. And so the imbalances put a disadvantage to us researchers from the low-income countries, especially because we know that we are at the forefront of global health practice, and therefore we feel that countries in the low and middle-income countries should start funding their own research gaps and priorities. In the Abuja Declaration, where they pushed countries to increase the funding for health to at least 15%, we have yet to see the majority of low and middle income countries attain this status. And yet, we know that funding for health and health-related research is what is going to reduce on the gap in funding, especially for professionals who seek to do research in global health and other agendas. As I have already mentioned, health and research cannot be separated. And we know that the highest level of research is innovation. The other good research is doing a randomized control trial, but obviously we cannot continue to negate the importance of even the primary level research. However, as we pursue doing research as local professionals, we would like to see that all resources are available, including good institutional review boards, capacity for all researchers to be able to evaluate and assess data that is collected, and the lack of locally generated funds for conducting research results in an inability for us to eventually develop those much needed innovations coming in from the low resources. I am going to quickly tell you about our research experience and looking for funding from our government. So in 2019, the government of Uganda, working closely with Makerere University, where I work, Makerere is one of the premier universities. We recently celebrated 100 years, explained to our Ministry of Finance the importance of funding locally generated research. And I'd like to say at this point that the government responded positively. Of course, not with big sums of money, but it is a beginning. And every year, the government ring fences $8 million to allow for locally generated research. As I speak, close to 1,000 different projects have been funded through the Research and Innovation Fund, fully supported by the government of Uganda. And 35% of these researches are health-related researches. We speak of amazing innovations that have been done, and I'll give quick examples such as the EpiTent, that is a mobile hospital that has been used in epidemics. We've also supported the development of a human biobank and various prototypes that include an incubator, oxygen pump, and various other innovations. So I'd like to say here that this is just a small drop in the ocean, but it can become a ripple effect if all countries in the low and middle income countries, all governments in the low and middle income countries start to fund locally generated research to support locally generated ideas and support the researchers. So we know that these inequities in research funding are not going to stop. And I believe that this conversation is just beginning. I'd like to urge all of us to see ways in which partnership between research and development can be emphasized continually, but also to appreciate that the world has limited resources. And these resources can be financial, natural, or human, but we all must optimize their use. The fundamental core of good partnerships is their ability to bring together people of diverse resources so that they can achieve more. And I hope that as we continue to deliberate in this panel, we shall create a situation where global health and global health research can be more impactful with greater sustainability and provide increased value to all. Thank you very much for listening to me, and I hope that we can continue this conversation. Thank you.
Thank you very much, Sabrina. Yeah. Once again, we've got additional contributions and suggestions on how we can start a long journey or strengthen our journey to solving our own problems. Let's go to the last speaker, the last panel discussant for the day. He's no other than Hossein Aklibari, sorry for the mispronunciation, but he's from, he's a faculty member of Novance Health Global Health Academy, although he's based in Australia. Hossein, feel free to say more and do your self-introduction.
Hello, everyone. I am Dr. Hossein Akbari Ali-Abad, a faculty member of Novance Global Health Academy in Novance Health, United States. I'm also a senior fellow affiliated with the University of New South Wales, Australia. Today, I ask for 9 minutes of your precious time. We will explore the past, discuss the present, and imagine the future. Shall we begin? My talk is about empowering low and middle-income countries in the age of digital medicine. Esteemed panelists, distinguished attendees, and dedicated advocates for global health. Once upon a time, in the hospital mentioned at the start of this meeting, I stood among countless desperate faces. Patients of all ages were struggling, not just with their ailments, but also with a dire lack of supplies and a stretched thin healthcare system. The tireless healthcare worker did everything they could, but it was often not enough. Surrounded by smartphones, the internet, and a wealth of documentation, I wondered, how can we leverage applicable digital medicine to better support this deserving community? Digital science and artificial intelligence have come a long way since Alan Turing's era. But as with all progress, there are challenges. Think about the Industrial Revolution. It changed the world, but not all parts benefited equally. Today, AI has the potential to either bridge the technology gap between high-income countries and low and middle-income countries, or widen the current digital division, emphasizing the importance of SDG 10, reduce inequality. Let's touch on a new age concern, digital neocolonialism. This refers to the modern-day control or influence by powerful parties over the weaker ones, much like old colonialism, but without direct political control. Historically, colonial powers had direct control over people. However, in today's digital age, terms like digital phenotyping and digital neuromarketing become significant. Digital phenotyping, which uses data from our digital devices to assess our mental and physical health, and digital neuromarketing, which looks at how our brain and body react to marketing stimuli, raise major concerns when combined. Just this mix alone is alarming, with the potential to deeply affect our choices and exploit us. More importantly, the integration of these tools with illicit data from the dark web, which is an encrypted and hidden section of the internet notorious for illegal activities, magnifies the potential risk and consequences. The idea that individuals could be manipulated from the inside, especially with the integration of digital health advancements, suddenly becomes a tangible reality, rather than just a plot from a science fiction story. It paints a daunting picture where personal data can be misused, particularly as healthcare becomes more digitized. For me, this is especially concerning in low and middle income countries, where there might not be robust regulations to protect digital rights. Healthcare in Africa has been on an upward trajectory, both in terms of quality and tech adoption. Meanwhile, there is an untapped treasure trove of historical patient data. If analyzed appropriately, this data could transform African healthcare by making treatments both effective and cost-efficient. There are success stories like Zambia's digital COVID-19 tracing, Rwanda's use of AI in logistics, and Mali's blockchain use in rabies control, aligning with SDG 9, industry, innovation, and infrastructure. These stories inspire hope. Meanwhile, they make us ask, how can we propel similar digital revolutions in regions still facing basic healthcare challenges? How can we make sure these transformations amplify healthcare benefits for those people in those contexts, considering their strengths and, of course, limitations? The path forward is mutual and respectful collaboration. As the tech leaders in high-income countries surge ahead in AI, it's crucial to ensure low and middle-income countries are not left merely as spectators. They should be co-pilots in this journey, highlighting the spirit of SDG 17, partnerships for the goals. One of my suggestions would be basically Centers of Excellence for AI and Global Health Research. This can establish with the decolonized approach. These centers would support data-driven policymaking that reflects local context and predicts health crises. They would shift from reactive to proactive decision-making, involving communities for relevance and inclusivity. Low and middle-income countries should partner with AI tech giants, global health organizations, and experts from high-income countries. This collaboration can produce AI solutions tailored to local health challenges and culture. Education and capacity building are paramount, echoing SDG 4, quality education. There is an urgent need to strengthen AI education and capacity building in low and middle-income countries. This not only refers to formal academic programs, but also to hands-on training, workshops, and boot camps. Local governments, in collaboration with global organizations, should create scholarship programs specifically focused on AI in healthcare, ensuring that a new generation emerges adept in both medical knowledge and the nuances of the AI. Of paramount importance, a well-defined set of regulations and ethical guidelines need to be established, highlighting the principles of SDG 16, peace, justice, and a strong institution. This framework, co-developed by international bodies and local governments, should prioritize data privacy, patient safety, and equitable access to AI-driven medical solutions. In conclusion, let's not be mere bystanders of the future. Let's shape it. With AI and global health as twin pillars and an acute awareness of our shared history, we can journey toward a world where technology empowers all, sidelining none. But let's not be naive. Remember our COVID-19 motto of nobody left behind? Yet, while certain regions managed to weather the storm, Africa bore a disproportionate burden of the crisis. Let this be a lesson and a call to action. as we embark on our technological advancement, let's remember the tale of Icarus, who flew too close to the sun with the wings of wax. It's a reminder of the dangers of overambition without preparation. Our approach must be grounded and thoughtful, ensuring we move forward together toward a brighter and, of course, inclusive future. Thank you so much for your attention.
Thank you very much, Hussein. That's yet another great contribution to this session this morning, this afternoon, or this evening, wherever you are. Now, we are going into a panel discussion, and I'll be asking each of you some question to which feel free to respond as you want. Maybe just to pick up the momentum from Hussein, from what you've just said. There seems to be a lot of hope in digital innovations and advancements. There seems to be a lot of hope in artificial intelligence, and there's a lot of talk about artificial intelligence these days. And yet, this artificial intelligence could actually widen the gap between the high-income countries and the low-resource environment. So, Hussein, I want to ask you a question. What kind of considerations, therefore, of course you've mentioned some, but we want to push this to yet another level. What kind of considerations should be in place when implementing digital medicine in low and middle income countries? And indeed, digital medicine is with us in these countries. So, please.
Oh, thank you. Thank you for your nice question. I'm thinking about this. We have, I just make it simple and then we can dig in it forward. My concern is that we have a local problem that needs local solutions, but we can use novel tools which are available. So my main consideration in using digital medicine is that the solutions should come from the local people who are trained well with the AI. This is very, very, very important to highlight the contextual knowledge. This will also address the cultural sensitivity by itself, because I, as a foreigner, may miss many cultural sensitivities when I'm going to another place. So what I suggest is centers of AI, which could be supported from outside and also by local governments that can work on this. And this is all my points in that regard for now.
Thank you very much. I'm sure we will dig deeper with the audience after this. Let me go backwards. The reverse order of the presentations. Chirazo, what should we be communicating? You've talked a lot about our countries, and our countries need to step in, pull up their national resources, and so forth. What should be communicated to the African Union and the United Nations and any other big funders and partner institutions? Communicating to them regarding what must be done to build high-quality human or affordable technological capacity in health. And this question links to what Hussein has just said. Although he limited himself to digital innovations. But now technological advancements are affecting health care, they're affecting health services. What should we tell the UN? What should we tell the African Union and so forth? WHO.
Thank you, Professor Sowakambo. I'm not sure I have the answers to this question. It's a difficult one in the sense that, like I said, you know, since 2001, at least the Abuja Declaration was expecting our countries to allocate at least 15% of their national budget to health. And most countries, I mean, Africa has got more than 50 countries, and as far as I'm aware, at any point in time over the last 20 or so years, less than 3 of them have actually achieved this target. And most of the things that we're looking at, or what we would like to be addressed, needs financing. And like I said, most of our health programs, especially with HIV and AIDS, we have dependent on the international global health partners to help us to deliver services to our people. And basically, I'm saying that this is not right, that we should not sit back as countries. The AU should, I'm sure they probably are discussing in their various fora to say that we need to find ways of financing these programs using our own resources. And the question might be to say, given that we say Africa has so many resources, are we going to say we are failing to use those resources because they are all, as Mitra said, they're being exported out of the country either by our international partners or by ourselves? I don't know what the answer is. All I know is we need to be able to use these resources that we claim to have to improve on our the various things. Like, for instance, if you look at digital technology, I know Hussein is talking about AI, which is a kind of a higher level of use of this technology, but we are still struggling with the basics, you know, access to internet, which everybody, you know, in some countries they take for granted. You know, we struggle with that. So I'm not quite sure what our countries should do. All I know is we are failing to deliver the basics that will allow our people to use all these new technologies to make life better for us in terms of all the SDGs. You know, you can sort of see how the technology can be used at various levels. You know, farmers can use technology to check what's happening on their fields. I know Hussein has talked about AI, but sometimes we can't even in terms of policy decisions or policy making, we may not even have access to the data that we require because we don't have that digital technology that will allow us to have this data that we can then use to make appropriate decisions. I'm not sure whether that's the problem, you know, that we don't have the data to make the right decisions for our settings. I'll stop here, Prof.
Thank you. Yes, again, there's food for thought in your response. We are still struggling with the basics, and yet the world is moving on to the more advanced. And if we stay with the basics, the world is moving on. It's not waiting for us. So how can we live in two worlds at the same time? Dealing with the basics and also dealing with the more advanced. The audience, of course, will help us to make some further suggestions, I guess. Sabrina, given the superiority-inferiority complex that low and middle income countries may be having. And that keeps us somehow behind. How should we or the LMICs should they be expecting to receive support from high-income countries forever to improve health? I do recall that this was touched upon in the presentation. But should we just say we now need to stand on our feet and make sure that happens? But it will not happen because we say so in words. It will have to happen because we are acting on the determination. What would you suggest?
That's another very complex question, Professor Sewankambo. However, I would like to say that there's always a beginning, and it is never too late to start. I know that whereas Uganda even reduced her budget for health by about 40%, and our budget for health is 5.1 of the national budget, having other things as priorities, including defense, transport, etc. I'm happy to say that there's now collaborative agreements, and the science and innovation funding in our budget this year upped by over 40%. So we can gain somewhere and lose somewhere. But I want to say that inequities cannot be resolved automatically. We all need to work at this. And it starts with conversations like these, pushing for a paradigm shift and reducing on the power imbalances. Clearly, the first world is years ahead of us, but we can only start to move towards where they are. So that's all I'll be saying for now. Thank you.
Thank you very much. That these conversations are important. And we should keep on with the conversations while we find a way of moving forward at the same time. Vincent, I'm back to you. You talked about power and its impact on global health and how it is used, and the challenge of global health itself and definition. How has colonial history and neo-colonial present impacted the mindset of people in low and middle income countries? Because the mindset has a relationship to the superiority-inferiority complex related to health. How has it?
Thank you, Prof. Another question which we can spend the whole day discussing, but I'll try to be as brief as I can. I think the inferiority superiority complex really affects the intelligentsia, or the very well educated and the very wealthy, who have been trained in Western countries or have been too exposed to Western education, so that we aspire to be Englishmen or Frenchmen and so on and so forth. The ordinary person in the village really does not have this inferiority complex. They may see a white man and say, oh, maybe he's wealthier than me, or he's wearing a better clothes than me, but they are not. I think this complex is mostly affects us and not the vast majority of the people of the low and middle income countries. Let me just go back to the previous questions that you have posed. I think we should not forget that all this progress that we see in high income countries did not come just by mistake. They were all very poor countries, and that's why they migrated to the United States in droves, and that's why they came to Africa and conquered us. Once upon a time, they were very poor, and it's only wealth that has brought them to where they are. Wealth that has made it possible for them to educate themselves, give themselves good facilities, better roads, aeroplanes, etc., and develop artificial intelligence. I will give you an example of a country like Singapore. Singapore does not have much in the way of wealth. There is a comment in the chat box which I'm trying to address. If we develop our human resources, of course, we will need wealth for that. If we develop our human resources and process our raw materials and have industries that grow to be as powerful as those of China, which was a backwater about 40 or 50 years ago, but now it's landing people on the moon, then only then can we really start competing and bettering the health of our peoples and developing ourselves to the level of any other region in the world. Without wealth, we shall continue to be beggars and the backwater of the world.
Thank you. Let's go to our first panelist, Mitra.
Can I add a point?
Yes, please. Panelists, feel free to interject on a particular point of discussion.
Yeah, I raised my hand, but it possibly missed it.
Oh, I didn't. Yeah, I missed it.
Yeah. So about this question, I wanted to add something that from my observation in various countries, there is a prevailing notion that individuals with lighter skin may possess superior knowledge, particularly in medicine. This perception can be traced back to historical influences, as Mitra already mentioned, where Western colonizers promoted their methods as superior, causing some to question their indigenous practices in favor of Western approaches. I just want to say something, and that's, I think, enough, is that it's a reminder of how powerful past narratives can be. But let me emphasize, expertise isn't a skin depth. Knowledge and wisdom have no color. Thank you.
Very good. That raises more questions. But we may get back to that. If it doesn't, why are we where we are? So, Mitra, does colonialism really matter for or in health? How familiar are people in LMICs where you've traveled many times? How familiar are people in those places familiar with the origin story, which you gave us at the beginning? And what determines which country or communities are more or less in touch with this story?
Yeah, thank you for the question. I'm going to leave the first one for last. So the issue of which countries and communities are in touch with their origin story, I think is actually a really fascinating question that represents such an interplay of culture and social conditioning and access to media and what is taught in curriculum. And we even see that here in the United States, where the origin story of the United States in terms of the genocide of Black people from all over the world and the genocide of Indigenous people is taught so differently depending on what state you're in, what institution you're in, who your professor is. So in my travels and in my collaborations with global health teachers and leaders around the world, I've seen a huge range where in some countries it seems to be almost a daily conversation topic where a lot of people are really in touch with it. I've spoken to other people who think that it's really a thing of the past and we shouldn't really be focusing on it anymore. And most interestingly for me, in the courses that I've taught, especially to some of the medical students in the Caribbean who represent a very diverse population, a lot of those students have very personal experiences with colonization, with their families, with their ancestors. And I was honestly a little surprised by how many of those students had never had those conversations with their grandparents, with their parents, with their peers. And it seemed like the curriculum was more elucidating for them. But I would like, after I'm done speaking, to pitch the question to our panelists or to our audience, because we have so many people from around the world who can speak so much more to how much that story is preserved or lost in their respective communities. In terms of whether colonialism really matters for health, I believe it absolutely matters, because it is the foundation for all of our systems in the way that those systems interact with each other, because it is fundamentally ingrained in the way that we relate to ourselves and to one another on the individual, community, national, continent, and ethnic levels. Health itself exists within a far greater network of social support, cultural capital, financial resources, access to green space, emotional labor, generational trauma, secondary trauma, all of which are directly tied to social services, childcare, education, and legislation. And on a more individual level, we have all these studies showing that students perform better in school when they have a teacher of a similar background. And similarly, patients have better health outcomes when treated by someone in a similar background. So these biases and superiority, inferiority complexes play into every single interaction. And everything from direct patient care to team-based care to institutional policies in hospital and clinics to national and international sources of funding for healthcare-related research and care grants. So ultimately, in conclusion, the vast majority, in my opinion, of our conscious and unconscious attention, brain power, human resources are benefiting the in-group, as all of our structures, as rooted by the colonial model, were built to support. Thank you. And I'd like to pitch the question about the preservation or lack thereof of the story to panelists and audience, please.
Thank you. And that is a lot of food for thought for all of us. As individuals, we need to be thinking about that.
I think Prof. Vincent is also want to say something, but may I add a point as well? So first, Prof. Vincent.
Yeah, maybe just to say it is very important, the education that we get. Most of us, we get an education which tells us that the state of Africa where we are is not related to colonialism. It's just because that we are not, we are lazy, we don't work hard, we don't think hard, and so on and so forth. But I was fortunate to go to a school, to a medical school in Tanzania, University of Dar es Salaam, where political education was part of the curriculum, and I was conscientized from that time onwards. And many doctors, medical professionals in Cuba and other countries include political education in their curricula, and they make people aware that medicine is not just looking after the patient's TB and so on and so forth. There are many other factors involved. And lastly, Professor Nkambo did mention that, but if it's not skin color, why is it that we are lagging behind and so on and so forth? I think the person, if I'm right, the person who invented the computer was a Ghanaian who was living in the United States. And I think some of the people who, I think the lead mathematician in who launched the first rocket into space and it came back, it was a person of African descent. So I'm trying to say that to support what Hussein said, that really color has got nothing to do with intelligence.
And I think we need to give these examples to our young people and others to know that, you know, that statement is absolutely correct. And those examples will be very informative to them. So we've gone through round one of the panel discussion. Yes, please.
Yeah.
Yes.
Yeah, I think about the colonialism and education, and now everything is better. So a few years ago, decolonization was something like what in education, but now, so we can say globally there's a push to include colonial histories in education. For example, in 2020, a UK petition with over 2,500K signatures asks for Britain's colonial history and transatlantic slave trade to be mandatory in schools, in UK schools. However, the UK government, of course, declined this request, asserting that the existing key stage 3 curriculum provides adequate opportunities to explore these themes by teachers if they want, but such events worth attention. That was my point.
Thank you for bringing that up. And of course, it will not be easy, I think, moving forward. We just have to keep raising these issues, and the discussion continues, as was said earlier on. So I have a question, which is to all of you, and please chip in when you want. And the question runs like this: that can you share at least one very important development that African countries, on the one hand, but also high-income countries or partners, on the other hand, should implement to ensure that Africa is not left behind in achieving significant improvements in implementation of global health standards or activities? Whoever wants to start, I don't see a hands up. Whoever wants to start. Yes, Sabrina.
Thank you very much. I actually physically put my hand up. Thank you so much. And the question you ask is, for me, summarized in the Sustainable Development Goals. And there are clear targets that we must all look at. Zero hunger, zero AIDS, zero this, zero that. But the truth is, equity without consideration of pre-existing differences is unattainable. As I already mentioned, it's like light and day in some situations. I mean, recently I was visiting a hospital supported by Novance Health Sciences and looking at their skills lab. The skills lab was like 100 times better than some of the best hospitals in my country. And this was a skills lab. And so in order for us to reach where we should be, to ensure that the last child, for example, receives the basics of even things like primary health care, immunization, we need total commitment, and total commitment by all levels, including the high-ups in the government, the education system, the funders, and also having proper governance. There is no way we are going to attain equity in health and health for all where there is no good governance. I want to make a quotation from Denzel Washington. You'd wonder why I'm quoting Denzel Washington, but I like this quotation. And he said that without consistency, you're never ever going to start. And without commitment, you are never going to finish. So for me, the commitment is for all of us, from the top to the bottom grassroots, and ensuring that partnerships are realistic. Thank you.
Thank you very much. Dr. Ndilazo.
Thank you, Prof. Again, like I said, I don't know what to say, other than to say recently I was in a country that was supposed to have lots of sanctions but I was impressed by the development in that country. But one of the things that I seem to think may have helped them was because maybe they prioritized the needs of their people. I am not sure if our African countries are prioritizing our needs or the citizens' needs. Obviously, if you wander around some of our countries, you'll think that we are very rich. You know, look at the cars that we drive, maybe the houses that we live in. So the question really is, should African countries really think about prioritizing the needs of their citizens and just make sure that the funds that they have are actually put to that citizens' needs? For instance, I mean, currently, I mean, I was reading some forum where people were talking about the use of pension funds, diaspora remittances. You know, how can we harness those to make sure that the poorest of our people are taken care of, that we are not just thinking about ourselves, like Vincent said, you know, those who are kind of well-to-do, you know, we really need to think about the people that need our help and just make sure that our countries put funding into the lives of those people. Because I think at the moment I get the feeling, or looking around, I just think that's probably the reason why we are struggling. We as low and middle income countries, that we are kind of trying to live the life of the rich. Sabirina, you just mentioned the issue of the clinical skills lab. I mean, we'll probably end up with something like that in our countries, and yet we don't have a clinic that actually functions for that person who is in the rural areas. I think we need, within our countries, we need to try and bridge that gap between those who have and those who haven't got. The other thing that maybe for the high income countries, there was an article recently that somebody wrote about the fact that we have a lot of our healthcare workers who go and work in the high income countries looking after patients who are elderly or the aging generation. And so our countries are losing their healthcare workers. So should we find a way that these high income countries can pay for these workers that go and give a service to their countries, and yet we in the low and middle income countries are losing? We can train the human resources, but the minute you allow them to go outside the country, they don't come back. So we keep losing. And there's a tendency by ourselves as well, when we see somebody that we think is good or somebody that we think is bright, we say they should go outside the country and they are lost to the region or the continent. Over.
Thank you. Any other contributions? I see a hand up, but okay, it has gone away.
I'm always here. So
okay.
Yeah. One thing that I want to highlight is that, to be realistic, while there is much emphasis on partnerships and collaboration, often global actions diverge from these ideals. You will know. For instance, in the past few months, we witnessed NIH introduce new grantee regulations that may go unnoticed in mainstream news. Unfortunately, only a handful of medical journals even chose to highlight such decision, which can perpetuate colonial tendencies in scientific research. So I think when we're talking about partnership, we should be very, very cautious. That was my point.
Okay. We should be cautious. Yes, please go ahead, Vincent.
Yeah, I think maybe, Prof, somebody needs to be looking at the panel, that there are some people who are asking questions at the chat box. And yeah, that's what I wanted to say.
Those questions are going to come up in another 10 minutes. The allocation for panel discussion is still going on. In 10 minutes, we should be there and give the audience opportunity to respond to those questions.
Yeah,
So
I was going to
let-
say, I was going to say, sorry, Prof, I'm very sorry. I was going to say that I like the contributions of my other panelists. They are really speaking to the issues. And what I want to say, maybe add, is that I think we should not forget that in the same way that we fought for independence, from maybe having civil disobedience, strikes, and so on in our countries, to dying in the bush for the freedom of our countries. I think we will really need to craft a way as low and middle income countries to really develop and become high income countries. It is not going to be given to us on a silver platter. It was not given to countries like China and Singapore. They had to do it themselves. I think if more leaders were, let me give a very provocative example. The coup in Niger, for instance. I know that many of us are saying that undemocratic, we should not encourage these things, and so on and so forth. But when you take into consideration that some of our leaders are allowing exploitation of our resources, like the lithium in Niger was being bought by France at about $2, I don't know whether per kilo, to electrify 40%, provide 40% of the electricity in France. And yet now when the coup has taken place, the leaders are saying that, no, we are not going to be robbed anymore. We are going to charge $40 per kilo, which is the rightful price of this product. So the more we really take things into our own hands and free ourselves and attain economic independence, the better for us. Sorry, that was long-winded.
Thank you very much. That question links nicely into what I wanted to ask Mitra. But let me assure our audience first that in about 8 minutes, we will be beginning to address your questions, and you feel free to make suggestions and so on. Now, for the panelists, please be brief now to 1 minute or two so that we don't disappoint our audience. Mitra, linking to what Vincent has just said, to what extent does coloniality and neocolonialism actually impact wealth of nations and wealth, determining the health status of the community? Was I clear?
Yes. Yes, thank you for the question. And I wanted to just respond to the last speaker that, yeah, I hear that loud and clear, and I could not agree more. I don't think that we can trust the in-group or the people with the greater power to make equitable, ethical decisions on behalf of anybody. I think we need to restructure everything so people are making decisions for themselves and their own communities, because I think at this point we can all agree that that system is not working. In terms of coloniality and neocolonialism impacting wealth, money is power and power is health. Coloniality is what created these disparities in wealth and resources. Neocoloniality is what's maintaining those disparities as a status quo. We use the example of the COVID-19 pandemic ad nauseum, but it really does demonstrate the imbalanced, desynchronous world that we've created when it comes to justice. All it takes is a moment to conjure in our minds the many layers of inequity in the global response to the pandemic, who had access to resources and human power to create and disseminate the vaccines, who received the vaccines, who was the last to gain access or never had access, who created the evidence-based principles of safety precautions, which principles were envisioned to function within. And, you know, a really short other example, I'd love to use the example of HIV, comparing in the US who is impacted by HIV, what their life expectancy is to average, and then taking the macro scale and comparing that figure to who is globally impacted by HIV. And some of us have been to this village where HIV was first discovered, where the HIV rate is still close to 50% and the life expectancy is 33. So when we talk about this trickle-down theory of technology, I just think back to how much it actually widens the gap. Thank you.
Thank you. Vincent, I had a question for you, but I'll change it because you've addressed the question I wanted to ask you. What now I want to ask is, you know, you said that these countries were originally poor, and now they are very rich. How did they break out in the bondage of poverty to get where they are? Can we learn any lessons from those, or some of the experience should never be repeated? Get out of poverty using those experiences. Briefly, 1 minute or so.
Yeah, you said I should be brief. Singapore developed its human resources. And again, Singapore used a socialist system whereby big companies were set up by the government to manufacture and to do many other things. Singapore made the government build houses for its people. The government was very involved and is still involved in infrastructure and so on and so forth. China protected its industries. It started doing industries, and for a long time, multinational corporations could not easily come and set up shop in China. And instead, they even say that if a multinational corporation wants to come into China, they must bring their technology and share it with the Chinese. Briefly, other people could contribute, and there are many, many other things, but briefly, I think I've touched some of the main things.
So that leads me to ask Sabrina, how can equitable resource mobilization and financing become a reality to improve global health?
So I'll just say, if somebody gives you money to build your house, they will actually tell you where to put your master bedroom or even your bed. And so if you are the one that builds your house, then you're likely to put your bedroom wherever you want. And therefore, we as Africans, we as people from the low and middle income countries, have to pull up our socks and promote Afrocentrism, Pan-Africanism, and start this training right from when the children are little. I want to say that it is ironical that in many schools, even our local dialects are punishable if you speak them. But in countries which have progressed, I know that Professor Setare gave the example of Singapore and even other countries, the countries in the BRIC nations, they speak their own languages. Recently, I was in Thailand, and there is no way that the Thai people will start with English and not Thai. Language is a way to continually colonize our brains. And I'm not wanting to be political or anything, but I want to say that whereas we are building partnerships, we also need to solve our own problems with the little resources that we have. And on top of that, use the resources that we have frugally. Thank you.
Thank you. Let's go to Zimbabwe. Yes, to Zimbabwe again, Dr. Chilazo. Is it time to expect our leaders to be judged on how much economic independence they get for their countries? Briefly.
Yes, I think it is time for them to be judged that way. And following what Professor Clare said, I just wonder why, with all this traveling that they do and all these meetings that they have between the low and middle income countries and the high income countries, our leaders don't seem to learn and sort of pick up the good evidence, the good practices that maybe it may be happening in other countries, whatever it is that made Singapore good, develop in such a rapid manner. Why can't the Africans pick on that? Is it because people just don't want to learn from other people? Because that's what we are doing all the time. We learn, we do things, and we learn and we improve on what we have done. But are we saying that our leaders in the low and middle income countries, I'm talking about maybe Africa now, they're not learning from what's happening in other countries that have sort of improved or developed themselves within a short period of time? I'll stop here. Thank you.
Thank you very much. In 1 minute, I want to get to the audience's questions and comments. But I'll be doing a disservice to Hossein if I don't ask him a short question and a short answer. How do you think the centers of excellence in artificial intelligence should work? I go back to that because it's a hot issue.
Yeah, this is a very, very relevant question, and thank you for asking that. Because I have to talk very, very short. I just say, in 2010, a paper by Henry et al. Coined the term weird to describe a lack of diversity in research. So weird was basically stands for Western, educated, industrialized, rich, and democratic. And the current literature in many fields is based on this kind of population, especially when it comes to newer kind of science like vaccines, like digital medicine and everything. I think one major point of those center of excellence that I already mentioned is they will work on cultural and diversity and what the really solutions are. The solutions are in that community. So the idea that local solutions solve local problems is really important, especially when we get help from around the world. AI can help with many local issues, but just having a tool isn't always enough. Let me give you an example, just very short, my personal experience. I'm originally from Iran, and in parts of our country and other places in the world, there is a disease called leishmaniasis. Imagine a young lady with a big scar on her face by this disease. So diagnosing this disease is very challenging clinically. It will help if you often look at it under a microscope, but there aren't always enough experts to do that. So my team and I made an AI tool that detects this disease on skin. It works really well in a center in Southwest Asia, in Iran, and we've even get few patents on that. Even the results is published in a peer-reviewed journal. But what happens now? Will others start using this tool in Brazil and, I don't know, Middle East or everywhere? There are many, many places affected by this, or grabbing this idea and use it. So what was the ultimate result? Just few people to benefit locally? I think that these centers of excellence are the answer. They can push forward tools like ours, help people work together, and ensure that good ideas get to places that need them. Thank you.
Thank you so much. Panelists, there is a question that is in the chat box. And somebody wants to, this is
I think Mitra wants to say something.
Mitra? Yes.
Thank you. I'll keep this really short. I just wanted to comment. I love everybody's idea of communities in low to middle income countries feeling empowered to take more space on the global stage. Speaking on behalf of the high income country side, I think it's really important that we also acknowledge that at the end of the day, our colleagues around the world are going to be limited because people in high income countries are controlling the policies, the structures, the education, the research, the funding. And for that reason, those of us that are passionate about this need to really encourage that we educate our faculty and our physicians in training, global health leaders in training, and make sure that, again, they get in touch with this origin story so that then they see the value in frame shifting and moving aside from leadership roles and giving those leadership roles to our colleagues in low and middle income countries who should be the ones leading the way. So on our side, I really see that we have equal responsibility to recognize that power imbalance and share the podium to the people that should be leading the movement. Thanks.
Thank you very much. That's very encouraging. We should look at that side of things again. But let's deal with this question from the audience. It's about any suggestion about human resource capacity building as a way forward. I'm not quite sure what the questioner was thinking about. Maybe if he can elaborate the question, that's fine too. But does anybody want to give the question a start? Any suggestion about human resource capacity? But it has been touched upon a little bit in the last several minutes.
If I may, Prof.
Yes, please.
Yeah, I think if we can really concentrate on teaching STEM, science, what is science, technology, the STEM subjects. If we concentrate on teaching the STEM subjects and also teaching people to do agriculture, fit pipes, to be builders, I mean, the technical things, I think this will help in terms of human resource development. I think this is what a country like Singapore did.
Okay. And in our countries, we are perhaps looking down upon that kind of training and not giving it a lot of thought and push forward. This might be a common issue around these countries. Do you have any information on that? Vincent?
I think it used to be looked down upon. I mean, these kind of technical, these trades used to be looked down upon. But now that people are finding that if they go and read history and English at school, when they go into the job market, they can't find job. Now the young people are beginning to appreciate training in the trades and other technical fields.
Excellent.
But during my time, it was looked down upon. Yeah.
And my time too. But it was still being pushed by governments, you know, that some people should end up in that direction. Now, the one who asked the question on human resource is Muluak Geta. I don't know whether I mispronounced the question. Do you want to say more about that, what you asked? Have we addressed it well enough.
Okay, thank you so much. It's already addressed because HR is a big issue for collaboration, also to collaborate with others. We need an HR for leadership. Everything needs an HR development. So it's all addressed by the panelists. Thank you.
Thank you so much. Is there any other comment or question from members in the audience? Before I give your time back to the panelists.
Chair, there was a comment from Janat from Uganda. Maybe she could state it herself. Jamida Nakato.
Jamida, are you still there?
Hello, can you hear me?
Absolutely, loud and clear.
Yes, thank you very much for this nice and thoughtful presentation. I have also learned a lot from it. So I was when I was listening, I'm hearing issues of resource constraints. Can we, as African countries, think of ways in which we can come up with local solutions with the resources we have at our disposal? Because I am in my chat, I was giving some suggestions of what we can actually make use of. For example, can we think of improving our health-seeking behavior? If you look at an example I can give, in Uganda, when you're taking children to school, you are asked to fill a medical form. You are asked to make sure that your children go to see the doctor, and then a medical form is filled. Can we think of ways in which this can be accelerated beyond? Because some of the diseases that people are facing in Uganda today, they can actually be avoided. But can we enforce the health-seeking behavior, like in organizations or something like that? If we can enforce in schools, we can also think of enforcing even at our workplaces, so that we can improve health-seeking behavior without the diseases getting to the hospitals. Then another thing I was thinking of is, can we make use of information systems? We already have systems. For example, here in Uganda, we have systems that are already working. Government is government has a system of issuing permits, driving permits, and also has a system of issuing, I think it is permits and then passports. But if you look at the way that system works, you find total equity in that system. So it is easier to get a permit. It is easier to get a passport. Can we think of ways of improving the health sector by using our information systems? Why would a file get lost? Why would you sit from 5 o'clock, 5 a.m. just to see a doctor who is coming in at midday? Can we think of using our systems which can be onlineized, the databases are available, people's information is fed into the files, information is fed in, appointments can be done online? We can think of ways that we can use the existing systems to improve our healthcare. Then I also, in my talk, I talked about knowledge management. When you look at our African cultures, we actually have, back in the day, people used to get medication, they used to get treated courtesy of nature. Can we think of revamping knowledge management? We have people out there, like in the villages, who are accessing, they can get medical care to treat malaria, to treat diarrhea, and some of these systems actually work. Can we think of improving our knowledge management so that we can improve our local content, our local systems, so that in where people cannot get these modern medicines, they can actually still also access the local medicines? So my suggestion is that we are thinking of ensuring that people can access healthcare all over, but we have resources within our we have resources within our control that we can make use of to ensure that everyone out there can access healthcare. So can we think of writing books, engaging those people in the community who have that local knowledge? And then we think of ways of producing the knowledge, sharing it, writing articles, and then that information can be disseminated throughout the patient population. So those were my suggestions. Thank you very much for listening.
Thank you very much, and I encourage everyone to look at Jamida's comments in the chat box. There's plenty there. Let's listen to Ndlovu And then we will go back to Sewami Colin. He's got a very interesting posting in the chat box. But Ndlovu first.
Okay, thank you, Prof. I just wanted to respond to the last speaker from the audience. The issue about information, having information systems. Again, I think, I don't know about Uganda, but I certainly know from our setting in Zimbabwe that sometimes we get the feeling that data is kind of, it's a secret, as a researcher, you have to start collecting your own data because it may be a bit difficult to use what's already within the system. And the question is, in our settings, in our low and middle income countries, if we look at data as something that needs to be hidden or we can't have access to it, how are we going to be able to come up with policies that are evidence-based? If everyone is going to have to start from scratch to collect data in order to answer a question. I think that's one of the things that I think is a problem in our settings. But then also the issue of whether, as I said earlier on, in terms of the technology to collect that data, simple things, having, let's say in medicine, patient electronic monitoring systems, we are still needing to sort out those basics so that we have databases that we can use to come up with evidence-based policies. So I think it's something that needs to be addressed. And then regarding the traditional medicines, I know WHO and some countries now have traditional and complementary medicines departments within the Ministry of Health. And in Zimbabwe, we do have that. And the idea is that we should try and harness this information that you are talking about, that the people have, so that, again, as part of maybe colonialism, we should not just be thinking that medicine is about the Western medicine, that we do have our own traditional indigenous knowledge that we can use to take care of health. Over. Thank you.
Thank you. I know that Mitra has her hand up as well as Vincent, but let me go first to Colin, because he posted a comment here, which I would love him to talk to himself. Colin?
Thank you very much, Prof. I hope very clear.
Yes, you are very clear.
My name is Colin Sawami, and I'm a medical student at Makerere University. I've really had submissions from all the delegates that we've heard from, and I really think, especially the one for Miss Mitra, really attracted my mind because she was talking about the origin story, and it's not the first time I've had this being spoken about. I've attended very many more meetings, and I've really had this as a point, and it's really becoming a household conversation of us going back to history and thinking that it's from our history that we have all this. But I believe we have been really independent for long enough. For example, for a country I come from, like Uganda, we are probably getting to 60 years or more of independence, and I don't think we should really be crying about these issues even after even 60 years later, after the colonial masters have left us. I believe our leaders, and it's incumbent upon us as medical professionals and people with knowledge in health to continue in so much in education. And I love what Dr. Sabrina Chitaka mentioned of how Makerere University, in conjunction with the Ministry of Health, educated the government, and through that they got funding for research. And I believe if we as people with knowledge concerning health continue to educate and sensitize our leaders about how important health can be and how much it can shift even in the spending of the country, I feel like we can make a little more effect, instead of rather crying of how the colonial masters helped us and stole from us and did everything that we continue to still whine about. Thank you very much, Prof.
Thank you. So that response, which is very good, takes me back to Mitra. She had her hand up, and then Vincent will come in after that. And then I'll go back to the chat box. Mitra?
Yeah, sorry, I'm actually not sure that I had my hand up. Maybe that was an accident.
Oh.
But regardless, thank you for this comment. I really appreciate that. And I will say on my end, I'm more interested in educating people in high income countries about that origin story, because on our end, we are sending so many people to communities over and over and over again who have no cultural sensitivity, don't know the history, and also don't know the continued colonial mentality that they are continuing to harm communities with. So my work is mostly about educating our side on the origin story. And really quickly, per Jamita's comment, I wanted to say I also love, Jamita, that you brought in the idea of interdisciplinary collaboration, because in the medical field, I think sometimes we are at fault of forgetting that we are surrounded by experts in so many other fields who in some ways have similar challenges, and this decolonization movement is not unique to medicine. So we really should be in constant discussion with policymakers, government, people pushing for education reform, and psychologists. I mean, there's just so many fields that we should really be drawing on and outsourcing. And I think that might also help. Thank you.
Thank you. Vincent?
Yeah, I would like, first of all, I'd like to thank Colin for that comment. Colin, your comment is valid, and while I accept that comment, I would like us to really remember that even though the colonialists left physically and gave us flags to say that we are independent, there is what we call neo-colonialism, which we should deal with. And neo-colonialism really is what is in a great way responsible for the way that we are, the structure of the world, financial systems, etc., etc. They keep us where we are. But having said that, the origin story and neo-colonialism help us to know what we are up against and to challenge our leaders to say that, look here, despite all these disadvantages, we cannot be crybabies. We are our own liberators. Thank you.
Prof. Nelson, you're mute.
Professor Sewankambo, you're still muted. We cannot hear you.
Sorry. Alexandra, you have a long comment here. Do you want to speak to it?
Can I add a point before that? Or
okay, you can go ahead. Then Alexandra will come in.
Yeah, thank you. One thing that I want to mention that Prof. Roddy mentioned already, but I want to highlight it more, is the political stability is very important to retain the local talents and, of course, attract investment by locals and international financial support. This is something that when we are thinking about Africa, this is a very, very, very important one. And also for customized solutions, I want to say something that could be controversial, but I want to say it loudly about low and middle income countries. And too often there is a temptation to engage in high profile research that may not have tangible benefits for the local populations for those in academia. Such endeavors which don't align with the community's actual needs should be reconsidered. Or I can use the word stigmatize very precautiously. For that, I think national guidelines for faculty promotions and research recognition must prioritize those addressing genuine health challenges not just accumulating publications, citations, whatever. I think it's vital to break free from this cycle of resource misallocation. I call it resource wasting, if I'm allowed. That was my point for now.
Okay, very good. Alexandria?
I didn't have any particular to add outside of what I said in the comments, just that I appreciate you all bringing this idea of sourcing solutions from local communities to this conversation. This is something that we strive to do in education, or at least at the nonprofit that I work for, we're trying to do it in education in the US. And I was just noting that a major problem that we continually run into is that those that are in power often do not recognize the expertise of local communities as expertise. And so I suspect that this is something that probably applies to this area as well, and just kind of wanted to bring up that likely a major pillar of this work is just getting folks to reimagine what expertise is and to value the inherent value and knowledge that people have.
Thank you for pointing that out. And sure, even in some environments, I know better that applies, that kind of thinking, and neglecting the expertise which exists in our communities. Ampalo Raja, do you want to comment on what you posted? Ampalo? If not, we will go to Thomas. Thomas?
Professor Swankambo, I hope I am audible enough.
Yes, you are.
Yes, thank you for the discussion. But I think in my own thoughts and in the very, very little experience I have is that we as the people who are maybe educated, who are great thinkers, we are in a different system, and the people who get to decide what maybe happens and how it happens are also different people. So for as long as we are maybe independent, for example, there are times when research findings come, but they don't inform the policies that the government is doing. The researchers are producing research, and the policymakers are in a different field. The two do not meet. I think for as long as the people who run the policy section are people who are not thinking in the same direction as we are thinking, we are still going to depend a lot on the support that we have from outside. The other thing are the things that we have as Africans. These are things which happen everywhere, like corruption, but I think it's overdone. For as long as we even generate our resources, but the resources can't even support a hospital, you may not think of supporting other areas because there's corruption, this is stolen. So it gets hard in such a setting. I think that's why we get to depend on a lot of external support. So I think from this, what I think is we need to see that such great brains, they move into like these ministries or even take up like political positions, and they are actually the ones who are driving the agenda that we maybe desire. That is my thought.
Thank you very much. Kathy, did you posted a comment? Do you want to speak to that, Kathy? That we shy away because we are politically illiterate and fear or feel inept to engage in such conversations. And I think she has a point there too. If anybody wants to add to that, yes, is that Sabrina?
Yes, I'd like to say thank you to everyone who has made comments. They are very useful in shaping our discussion. And just a thought about the politics of this meeting. Yes, human beings are political in nature. You cannot separate health from politics. You cannot separate finances from politics. But in this conversation, we really want to look at the shifting of power paradigms, and whether those power paradigms be a diversion or divergent views between the politicians and the scientists. I think our role here is to ensure that we bring together all these minds towards a common good. And the common good is to ensure that there's equity in health and health for all. I'll just quickly speak about what Jamida has posted on the role that social media has played in replacing the doctor. I usually keep posting on my Twitter handle, and I know that I'm followed by over 48,000 individuals, that you cannot replace a real doctor with being a Google doctor. It takes close to 18 years to train the basic layer of a medical doctor, and so treating yourselves cannot replace seeing a real doctor. However, I want to say that during the COVID-19 pandemic, there was a huge avalanche of misinformation and mistrust in the health system. So people have chosen now to self-medicate and seek healthcare from elsewhere. But we hope that as we resolve a lot of these issues, that our governments will come in and regulate the correct way to do things, develop guidelines. And we have global bodies that have enabled us to develop guidelines. But we need to ensure that rules are followed. Because at the end of the day, if you do self-prescription, and for example, you end up getting a cardiac arrest, who are you going to blame? So we need to be cautious and leave issues of the generals to the generals. I'm just quoting that from a Ugandan perspective, that we should let healthcare providers do the healthcare work, the financiers to do the finance work, the lawyers to do the work, but we should work collaboratively towards a common good. Thank you. Professor Sewankambo, you're muted again.
I don't know why it goes muting itself. So, Ampalo, you had wanted examples, and I wasn't quite sure what kind of examples. Please, could you give examples of implementation? So if you can clarify on that, I'm sure the panelists would be able to give examples of implementation. As you think about that, if you are there, there is Justice as well, who posted a comment. Going forward, Africa should indeed find African solutions. Again, you may want to expound on that. So, but first chance is Ampalo, because that comment came in earlier. How about Justice? Justice Ibrahim?
Yeah, thank you, Professor, and thank you, everybody, our panelists for today. This is indeed very insightful, looking at how we shift the paradigms of making sure that the global south, especially Africa, we are able to maintain our health and cope to those who have done. And as we were talking examples of Singapore and others, and adding on what I submitted, there is this common saying. I was looking through Yale University website, and there a phrase that I picked there, that the trained professionals who will graduate with the ability to think globally, but they are able to act locally. And so I was looking at Africa, even when this Dr. Kamida was presenting and talking about that there are some ways in which Africans use it to treat some medical conditions. So we need to advance and see how best can we make sure we draw back to African heritage without compromising the advancements in science and technology, so that we do things And this one does not stop us. We shall use available resources that we have, but also we shall continue and collaborate with the global forces. And Maestra has mentioned about low middle income countries collaborating with fellow low middle and income countries. So we need to collaborate together. And one of the friends hinted on corruption. And this comes back at politics. And you wonder, I feel like some of us who are on this platform would do better if they had a chance and also they tip their hands in the political control, because politics tends to shape most of the things. And I remember when Plato had to say that the punishment of not joining politics is being ruled by your inferiors. But in this case, I'm not certainly saying that our politicians are inferiors, but it is very important that, for example, on this platform, if we had people with such kind of passion also being a part of politics so that they can shape this, and then we have everyone brought on board so that the policies that we draw, we are able to follow up and make sure that they're implemented, because we understand that in most of these African countries, we have many good policies, but implementation hasn't been there. And with the political backing and the mutual understanding of all the players from bottom to top, we would get somewhere. But the thing is, we need to solve problems of Africa with a sense of understanding that there are solutions that apply better, putting cultural sensitivity in a context, and that most of World Health Organization programs and guidelines and protocols, they are best applied when we go back and tailor them to the local context. Thank you very much.
Thank you very much for those excellent points. Now, as you were talking, another issue came up in my head, and we have just over 10 minutes to close this meeting. Raising our voices, whether internationally, in international organizations, where, as we were told, the representation in those kind of fora is not democratic at this point in time. What should we do so that the African voices, so that voices from low and middle income countries are actually heard and are heard effectively? And the same, of course, would go to the regions, voices being heard, instead of people listening to the voices of the funders only, or most of the time, and yet the local voices are not there. I throw this question open to the panel to see whether you have something to say about that. Voices, because we keep hearing that on different panels, the African voice is not heard well. Chilazo.
Thank you, Prof. Again, I don't know if I have an answer for that. All I know is that we need, like for instance, in this case, if you look at Global Fund with 3 out of 20 board members coming from Africa, one would have to say, how do these, we need a sort of transparent way of knowing how people end up in those positions. One of the things I was thinking about was that perhaps countries should have some sort of human resource database for some of these potential members for these international global health boards, so that it doesn't become a question of who you know, whether you end up in those kind of settings. Because at the moment, I think well, I like maybe the audience to say I'm wrong, is to say it's really a question of who your networks, but from what we've just been discussing, we may not be that networked, from what Sabrina was saying about research, sometimes it's difficult to get, let's say, funding because you are from a low middle income country and maybe you're not that well known as a researcher, but there's need for people to be known. We need to have a way that the people that we think can sit in these boards in our countries, how do we know who they are? I'm not quite sure whether giving that responsibility to, let's say, the universities is the way to go, or whether it should be Ministry of Health. But I think we need to think about how we get the right people into those boards. Just like the audience member who talked about politics and how we are discussing this, and we are supposed to be educated, but we are not maybe sitting there in a political setting, maybe that I don't know. I don't know how you get these people that should sit in these boards, but we need to find a way of how we can get a transparent way of getting the right people into those boards. Over.
Vincent has a suggestion.
Yeah, I hear what my sister is saying, and I think I go along with what she's saying. I think one thing we should realize is that as long as we are small countries trying to outcompete each other to be liked by France or Britain, or to be liked by the United States, we shall always be little pawns who are voiceless. And as long as we have an African Union which depends on funds from the European Union to function, to run its affairs, we shall always be small boys who behave nicely, so that we don't jeopardize the monies, the support that we are getting from our masters. So it goes back to having African solutions, being brave enough to say, okay, let's go through a period of inconvenience while we build and consolidate our resources, our economies, and say no to being exploited. And then aligning ourselves with any other bodies, regional, or whether they are countries which say, Africa, we shall support you. When we are strong, we shall not beg to go to be represented in reasonable numbers in these places. We shall demand to be in those places, and we shall be accepted in those places. But as long as we are small, forget it. And as long as we are small, one thing that makes us small again comes to our voices. As long as we, as the intelligentsia of Africa, the educated Africans, only listen to CNN, BBC, NBC, and so on and so forth, and think that those are the only genuine sources of information, we shall ever be small boys of this world.
Thank you. Yes, Hossein.
Yeah, thank you. Thank you. I just want to make a very, very short point, and it's actually 2 points, but I wanted to highlight it based on my experience in a little, I can say very, very limited experience in global health. So I think when I'm talking about contextual knowledge, I mean, no matter how deeply one immerses in a foreign culture, they cannot truly grasp the lived experience and pains of those native to it. So this is especially crucial in crafting health solutions for African nations. I mean, while we're always talking about collaboration with global partners, and it has its merits. It's the intimate contextual learning from all local experiences that makes intervention truly resonate. The second point that I want to highly emphasize is that when we are talking about or education, upgrading the human resource and everything, you should really, really be careful how to keep them inside the country in a way that it's peaceful way, because I'm really concerned when we train some people in digital sciences in low and middle income countries, they may possibly leave the country very soon, and a kind of brain drain happens. So that's a mess, and that is my concern now as well. Thank you for the opportunity.
Thank you. In the last 3 minutes, we have to close this session. Colleagues, members of the panel, those in the audience, this has been a very rich discussion. And a lot has been said on different angles, as it were. It's very difficult for me to summarize the discussions that have gone on. But I think one of the key issues there is that we, those from Africa, but low and middle income countries in general, that we must ourselves get involved and not just stand by. We must recognize what the challenges are, for example, in our health systems, and then be prepared to do something about it, that no external voice will be able to replace us in what we think and what our priorities are. Also, that we must mobilize resources, internal resources, domestic resources, to begin a long journey where we contribute to our global health needs and other related needs that have an impact on the health of the population. And so this meeting should not be a one-off that we've discussed about democratization of global health stewardship, but rather a long protracted process. And we must therefore have follow-up activities and discussions in the various countries and also at a continental level or regional level, so that we can move forward at the end of the day and see results from those discussions. But if it is a one-off, then there is a danger there that everything will die down after this meeting and so on. And therefore, the call to action is that let's rededicate ourselves, let's rethink about many different things we've talked about, and we find a way forward. And we should be educating colleagues who are not yet thinking about issues the way we are thinking, that we should educate them. We should give them information. I mean, if people don't have information, it is difficult to get out of a closed box. So on that note, thank you very much for participating in this great session today. And once again, I thank the people whom I mentioned at the beginning, who have really put a lot of energy into this session to happen. And of course, the panelists themselves, because I know what they have gone through trying to prepare for this. Our audience, thank you very much for joining. Otherwise, we would have been sitting here without people listening to what we say. But thank you very much. And I think we close this session at this point of time.
Thank you, Professor Nkambo. Thank you.
Thank you. Thank you.
Everyone, especially Dr. Swankamba, Dr. Majid Sadiq.
Thank you so.
Thank you. Thank you,
Thank you.
everybody. Bye.
Thank you.
Bye.
Thank you.